Hello everyone, dear students. I shall discuss a neurodegenerative disorder, Parkinsonism, in two parts. In part 1, details of levodopa therapy will be discussed and the remaining drugs will be discussed. Neurodegenerative disorders are characterized by degeneration of critical neurons and nuclei involved in motor activity. Now, most important disease is Parkinson's disease. Others are Huntington chorea, amyotrophic lateral sclerosis, and Alzheimer's disease. I will be discussing other things later on. Today's solution. But we must realize that these all disorders are proteinopathies. There is a alpha-synuclein protein found in Parkinson's disease, Huntington proteins in Huntington chorea, TDP43, that is DNA binding protein in amyotrophic lateral sclerosis, and amyloid beta in the Alzheimer's. The proteinopathies result in oxidative stress, inflammation, excitation and toxicity, mitochondrial dysfunction, and ultimately death. Therefore, there is a degeneration of the nuclei. So, against this background, we will talk of Parkinson's disease and pharmacology of the Parkinson's disease. It is called as paralysis agitans because of movements, palsy. Mostly it is idiopathic, a degenerative disorder of advancing age, and it is characterized by a dopamine depletion due to critical degeneration, dysfunction of the dopaminergic nigrostriatal neurons, leading to imbalance of dopamine and other neurotransmitters, particularly acetylcholine, glutamate, and GABA. These are the two targets which we will be using for the treatment, dopamine and acetylcholine. Other causes of Parkinsonism include carbon monoxide poisoning, manganese poisoning, carbon disulfide exposure, and after viral encephalitis, which is rare. Often it is drug-induced Parkinson. The main etiological factors are genetic predisposition, oxidative stress that leads to generation of free radicals which damage the neuronal lipid membranes and DNA. The aging is also an important. As age advances, degeneration begins. Environmental triggers in the form of poisonings, infections, all may lead to Parkinson's-like disease. And one of the chemical exposure found to be directly involved in degeneration is MPTP. We will talk about in the drug treatment of Parkinsonism. This MPTP is activated as MPP plus and that causes neurotoxicity. Excitotoxicity of glutamate NMDA receptor may lead to calcium overload and that causes destruction. Drug-induced is mostly reversible due to neuroleptic antipsychotics, haloperidol, chlorpromazine, triflupromazine, and some antiemetic, most important metoclopramide, and prochlorperazine. Reserpine, it is mostly reversible. Tardive dyskinesia is prolonged. Otherwise, it is. Now, in idiopathic Parkinsonism, James Parkinson described the disease in 1817 and he termed it as shaking palsy. And the disease is the dysfunction in the extrapyramidal nuclei characterized by rigidity, tremor at rest, bradykinesis or akinesia, slow movement and brevity of movement, poverty of movement, impaired postural balance, propulsion, retropulsion, leading to disturbed gait and tendency to fall. Mask-like face, reduced blinking, Mayer sign, and cyalloria. Cyalloria means drooling of saliva, and because it is due to cholinergic over. The pathological hallmark of the Parkinson disease is loss of pigmented dopaminergic neurons in the substantia nigra, particularly pars compacta. And histologically, there is appearance of intracellular inclusion bodies called as Lewy body. They are actually aggregates of the alpha-synuclein protein responsible for neurodegeneration. A loss of 70 to 80% of the dopaminergic neurons in the extrapyramidal nuclei will cause Parkinsonism. There is a critical degeneration of the neurons will result in reduced dopaminergic activity. Parkinsonism is also characterized by non-motor features: anosmia, disturbed sleep, constipation may occur early, but late manifestations after movement disorder is depression, anxiety, dementia, and particularly occurrence of hallucinations, delusions, executive and visuospatial dysfunction, and that will ultimately result an elderly person to be homebound and bedbound and require social. These are the nuclei we call extrapyramidal nuclei: subthalamic nucleus, globus pallidus, substantia nigra. Features which are characteristic: degeneration occurs in substantia nigra only, globus pallidus, subthalamic nuclei, substantia nigra, and the combination of caudate nucleus and putamen we call corpus striatum. This is the stratoneurons or nigrostriatal pathways. They are actually shown to be showing degeneration, and that is important. Now, how does the extrapyramidal system function? It controls motor movements. Now, striatal control over substantia nigra and globus pallidus is through direct stimulatory pathway involving D1 and indirect inhibitory pathway involving D2 receptors. However, the net is a balance of the activity of direct and indirect pathways, and that maintains the motor movement, stance, gait. Therefore, it provides coordination by controlling motor cortex. Now, when in Parkinsonism there is degeneration, the direct pathway will show less stimulation and indirect pathway will show less inhibition. So opposite effect on the two pathways, it creates a reduced dopaminergic input and increase markedly the inhibitory outflow from substantia nigra, pars recta, and globus pallidum interna to the thalamus and reduce excitation of the motor cortex, and this imbalance activity will result in uh, abnormal movements. So this is a normal. When there is more inhibitory, there will be abnormal movements will appear because of poor motor control. So there is a loss of motor control through of cortex. In addition to this, there is overactivity of the acetylcholine or cholinergic system, and this overactivity will result in some manifestations, and it also shows that anticholinergic drugs may also be effective, those anticholinergic that go to the brain. So underactivity of dopamine is a key marker, but overactivity of cholinergic system is also a marker. We know dopamine underactivity, there is a loss of inhibition, and cholinergic overactivity causes inhibiting L-amino decarboxylase enzyme. So there will be more concentration of dopa that will leach into brain, where it is then converted. No, I am talking of peripheral inhibition of the L-amino decarboxylase enzyme. So, but central decarboxylase is active. So, in brain, dopa will be converted into dopamine, and that will be much better. So, we are inhibiting peripheral, not central. The strategy we use to increase the dopamine formation by increasing transfer or passage of levodopa from periphery to. Second would be whether in periphery or brain we use drugs that inhibit monoamine oxidase enzyme, those which inhibit monooxidase enzyme B for brain, which is present in the brain, and also inhibit central and peripheral COMT enzyme, so that peripheral inactivation of dopamine is inhibited, more levodopa goes, so that central COMT inactivation of levodopa is inhibited, so more levodopa is converted into dopamine. So this is an important group of drugs, monoamine oxidase B inhibitors and catechol orthomethyl transferase inhibitors, which are used as add-on drugs in Parkinsonism. Third way is to increase the activity of remaining dopamine receptors by using dopamine agonists. And fourth is to increase the dopamine release, whatever is available in presynaptic dopaminergic neurons and nigrostriatal pathways. We facilitate release by giving drugs. So such four type of strategies can also be useful. In addition to this, as discussed earlier, cholinergic overactivity is controlled by using centrally acting tertiary anticholinergic antimuscarinic drugs. These drugs enter brain and exert antimuscarinic. Now, classification of drugs is based on this concept. Central acting drugs that increase dopamine activity are levodopa, peripheral decarboxylase inhibitors, carbidopa, benzodiazide, dopaminergic agonists, bromocriptine, ropinirole, pramipixole, apomorphine, monoamine oxidase B inhibitors, salicylic and rasagiline, and COMT inhibitors, entacapone and tolcapone. Finally, facilitating dopa release is amantadine. Anticholinergics, which are tertiary and centrally acting, are most common is benzhexol, but others are there, procyclidine and piperidine. Some of the antihistaminics also have anticholinergic activities, and they are central acting, particularly conventional and sedating antihistaminics, promethazine. Now we talk of levodopa. It is the single most effective drug for the treatment of Parkinsonism. Levodopa is inactive and is a precursor of dopamine, and levodopa easily enters the brain. It reaches in extrapyramidal nuclei, nigrostriatal nuclei, and it is getting converted into dopamine there by a central L-amino decarboxylase enzyme. However, a large amount of levodopa is peripherally decarboxylated by peripheral L-amino decarboxylase enzyme in gut and liver. So very little dopamine reaches actually the brain. Now in periphery, dopamine is formed that acts on the peripheral organs, exerting adrenergic and dopaminergic effect. It also acts on chemoreceptor trigger zone, which is outside blood-brain barrier, so it may show vomiting. Some amount is converted into noradrenaline, as told you earlier, by dopamine beta hydroxylase enzyme. So there is a cardiovascular action shown by levodopa therapy. Therefore, only 1 to 2% of given levodopa dose crosses blood-brain barrier, taken up by the neurons, and then the formation of dopamine occurs. We need to give levodopa in very high doses when levodopa is used alone in the treatment of. Now these doses will exert CNS action. The main salutary actions are improvement in the motor movements. Bradykinase and rigidity responds quickly. person becomes more active, ability to walk increases, there is a reduction in the tremor with continued therapy, and secondary symptoms, stiffness, for example, postural, gait, handwriting, speech, facial expression, and interest in life all improve gradually with the important behavioral effects of the levodopa are elevation of the mood because there is a depression and increased sense of well-being. So it is a salutary effect in elderly person. In general, alerting response is improved. So response to reflexive response to external clues is also improved. There is some excitement in some persons, elderly persons. Usually, dementia does not improve, and some neuropsychiatric manifestations use of levodopa as side effects. Now we'll discuss cardiovascular peripheral actions. There is a cardiac stimulation because there is formation of noradrenaline and adrenaline ultimately, and dopamine itself acts as a vasodilator. There is predominant orthostatic hypotension. The reason is central and peripheral action. Central dopaminergic action and the noradrenergic action. But this side effect should be remembered. There is no hypertension, but there is orthostatic hypotension. Gradually, tolerance to cardiovascular action therapy. Levodopa reaches the chemoreceptor, triggers on, stimulates it, so causes nausea, vomiting. Gradual tolerance occurs. Some important endocrine effects are because of formation of dopamine. Dopamine is PIF, prolactin inhibiting factor, so there is reduction in the prolactin levels. Pharmacokinetics, so these are the effects of the levodopa alone. Pharmacokinetics is absorbed. The main problem is that it has a variable bioavailability which is critically affected by several factors. There are so many amino acids in the food that will complete for the carrier transporters of levodopa from lumen to intestine epithelia and from epithelia to blood. So there is a marked variation in the bioavailability. Protein-rich food reduces bioavailability. Gastric emptying, it is also an important factor. If it is less, absorption is very slow. Therefore, one tries to use a sustained release formulation instead of a short-acting simple formulation. The problem with bioavailability is because of high first pass effect also. Inactivation of the levodopa or conversion of levodopa to dopamine peripherally in intestines and liver during plasma half-life. So overall we will see that because of these peripheral effects, if we give 100 milligram, there will be only 30 milligram brain, of which only 3% will go. So 3 in the brain, therefore brain will receive only 1 to 2 milligram. The rest is metabolized in gut, pre-systemic, or converted into the dopamine and noradrenaline causing tissue toxicity. This is an important aspect to understand how levodopa therapy has limitations. Any drug that can, this is important to understand, that decrease the peripheral conversion of levodopa to dopamine, and drug will be peripheral decarboxylase inhibitor that will be beneficial because it will increase the levodopa availability. We will talk of first adverse effects of levodopa and then other groups. The initial therapy may show vomiting mostly, but tolerance occurs. Postural hypotension occurs as many as 1/3 cases. It is usually asymptomatic unless patient is taking other antihypertensives. Adverse drug interaction and fall may occur. Cardiac arrhythmias because of conversion into noradrenaline and adrenaline and exacerbation of angina. Therefore, cautious should be exercised. Other adverse effects are seen in prolonged therapy in the form of appearance of abnormal movements after initial improvement in tremor and rigidity. Abnormal movements are in the form of dyskinesias and that is because of alteration in the firing in the globus pallidus interna and substantia nigra pars recta. The burst activities will result in abnormal filing and abnormal motor movement control over brain. Facial tics, tongue thrusting, chorioathetoid movements of the limbs occur and no tolerance occurs. So some abnormal movements will appear. Continued levodopa therapy and patient will continue to show that these abnormal movements may be due to formation of reactive metabolite from levodopa. And behavioral changes also appear with continued therapy in the form of troubled thinking, cognitive changes, psychosis, depression, anxiety, impulsive behavior, suicidality. Few may show sexual behavior changes, and they are termed as dirty old man because sexual feelings may be inappropriate sexual feelings. The drug holidays, stopping drug, may reduce these behavioral problems. Fluctuation the response after 2 to 5 years of therapy. One is called as wearing of effect. The dose of levodopa has effect for 1 to 2 hours, but thereafter rigidity and akinesia occur. They are not abnormal movement. They are the part of the Parkinson's disease which appear. And this wearing of occurs at the end of the dose. So either you give a long acting or you give frequent doses. Now use of levodopa alone causes more problems because there are fluctuations in the response. Another is on-off phenomena. Because of rapid fluctuations, there will be good periods and patient almost sudden will be having akinesia. So on-off periods are also seen with conventional formulations. One gives either a sustained release formulation, dual release formulation, that is intestinal capsules, or another one is that carbidopa levodopa intestinal gel through gastric tube has been suggested to reduce the fluctuations. Some use inhalational levodopa to avoid on-off phenomena. Abrupt withdrawal of levodopa will cause neuroleptic syndrome sometimes, not common, as seen with other anti. On-off phenomena can be shown or depicted in the form of the wavy on periods followed by off periods. Off periods coincide with wearing of effect. Drug interaction because of the activity of peripheral decarboxylase requires vitamin B6 as cofactor. So if we give vitamin B6 or B complex containing B6 with levodopa alone, then more levodopa is converted into dopamine in the periphery, in liver and intestine or in the blood, and very little goes to the brain. So this is called as pyridoxine antagonism. You may remember here that vitamin B6 is always given along with isoniazid to prevent peripheral neuropathy. And the opposite is B6 should never be given when levodopa is used alone for Parkinson. So it loses effect. Antipsychotic drugs may be interacting because of common dopamine receptor D2 antagonism. They will increase Parkinson-like syndrome and decrease levodopa efficacy. Particularly phenothiazines, beta-arabinoids are marked D2 antagonists and they show drug-induced Parkinsonism. Anti-dopaminergic antiemetics, particularly metoclopramide, crosses blood-brain barrier, so it reduces therapeutic efficacy of levodopa and produces extrapyramidal syndrome. So should vomiting develop in a patient of levodopa taking patient, then never give metoclopramide. Instead give domperidone although domperidone does not cross blood-brain barrier, but it reaches CRTZ because it is outside the blood-brain barrier, and therefore it is useful in reducing the vomiting due to levodopa, but it does not produce extrapyramidal nuclei as seen with metoclopramide. Reserpine is an old drug that blocks the levodopa action by blocking the uptake and emptying the stores. So it is less often used, but it may also have opposite effect. Anticholinergic drugs have additive therapeutic effect, but because they delay the gastric emptying, so there is reduction in the levodopa bioavailability, and that is the slower absorption. Non-selective monoamine oxidase inhibitor. Now I told you monoamine oxidase is an important enzyme to inactivate levodopa, dopamine and noradrenaline. If this inactivation is inhibited, there will be excitation, hypertensive crisis, and so these are the important interactions. Contraindications are avoid in psychosis, narrow angle glaucoma, along with monoamine oxidase inhibitors, and avoid this to avoid this syndrome. So this is the one group of drugs which I have discussed. Place of levodopa, a good drug, but lot of adverse effects and limitations. Now, peripheral decarboxylase enzyme activates levodopa to dopamine, and this dopamine is not available for entry into brain. So what we do is we reduce the conversion of levodopa to dopamine by inhibiting L-amino decarboxylase enzyme in intestine and liver, and this will increase the levodopa blood levels, that more will go to brain, where central L-amino decarboxylase is not inhibited, so it will convert it into dopamine. That will exist. More levodopa is available, we reduce the dose of levodopa from 2 grams to 1 gram, for example, from 3 grams to 1 gram. So adverse effects will be less. One of the main advantages, adverse effect will be less. There are other advantages. Now look at this pictorial. Normally only 1% goes to the brain. If we give 100 milligram, 1 to 3 milligram goes. But when we give levodopa with carbidopa, the dose is less. Look at the size of the pictorial blue arrows. The dose is less, but more goes to the brain. Of this small 100 milligram, now 10 milligram goes to the brain because peripherally levodopa is not metabolized further. And this is the way we allow more levodopa to go to the brain, where it is converted into dopamine. The benefits of combination. Plasma half-life of levodopa is increased. Dose of levodopa is remarkably reduced to 30%. Reduction in the systemic adverse effects is there. Nausea, vomiting is less because total quantity is less. Cardiac arrhythmias would occur minimally. Pyridoxine antagonism is not there. Now here with levodopa and carbidopa we can give pyridoxine. Fluctuation, the response are less, and there is overall improvement of the motor control. But there are problems: involuntary movements, behavioral problems, excessive daytime sleepiness, postural hypotension. They may increase with the combination. So using these limitations, we use the combination for. In practice, a ratio of 10:1 of levodopa carbidopa and a ratio of 4:1 levodopa benzerise are available in the form of plain and SR. In general, we use SR. A tablet may contain 110 milligram or 275 milligram SR tablet to be given twice daily. So this finishes the part 1 of the drug treatment of Parkinsonism, and we will follow part 2 subsequently. I hope you understood the basic pathophysiological mechanisms, the reason for abnormal movement, and how we develop the drugs to control the abnormal movements in Parkinsonism. Now, thank you very much.